guys, welcome back to Do I Look Sick with Sickle Cell Awareness 365. Again, I am Mia.
And I'm Jennifer, and it's good to be back with you today.
We have an amazing guest today that's going to talk a lot about health inequality. We have Dr. Z, as he is affectionately called.
Excellently known.
And Dr. Z, tell us first what it is that you do.
Well, first of all, thank you for having me on. So my name is Amar Zaidi, and you guys are right. They call me Dr. Z. I'm a pediatric hematologist in Detroit, and I specialize in the care of children with red blood cell disorders, but specifically, I take care of sickle cell disease and thalassemia patients. I research biomarkers of pain and disease, but I'm most interested in technology and how we can use technology to change healthcare, how we can change technology to fight um, stigma, how we can use technology to fight misinformation that exists. That's sort of become my area of passion, and that's what I keep myself busy doing.
Awesome. Well, on behalf of the pediatric sickle cell patients, we they thank you for all that you do, and even working with the transition age. It's very we appreciate everything that you do with the sickle cell community.
And
So
it's so necessary, especially that transition part.
yeah, yeah. So let's stop. You have a TED talk, and I shared
Yeah.
the TED talk with a few different people. I absolutely loved it because you hit on so many important things. I actually love the way that you broke down what sickle cell is to the audience that you have. You made it pretty plain and simple and not too much medical jargon and too much science in it, but I thought that was really good, a really good explanation. And even going into the stereotypes and the inequalities that we have to deal with in the healthcare system. So I'm gonna start
Thank
with,
you.
you're welcome. I'm gonna start with, because we work closely with um, the transition age, as I mentioned earlier, and I know one of the issues that I have is we teach them about their bodies to know what their numbers are, what their medications are, and all that good stuff, which is awesome that they know that. But it's troubling when they get to adult health care with this knowledge and have to face so many different stereotypes and pushbacks and attitudes because they know so much. How do we how do we fix that?
That's a hard question. I mean, I think that always going to be there's always going to be challenges, right? You can't predict how your doctor, how the healthcare system is going to react to you as a sickle cell warrior. The one thing that is the one thing that the healthcare system can't take away from you is how much you know about sickle cell disease, right? And if you are knowledgeable about the disease itself, I tell my patients when they're in that transition phase, my goal is to ensure that you know more about sickle cell disease than anybody else that's going to be in the room with you, because that's something that can't be taken away from you, right? That's something that is um, with you forever. Now, there are colleagues of mine. There are instances where healthcare providers take that as a threat, right? Where they feel threatened by your knowledge of the disease, and they feel like you are undermining them.
Mm-hmm.
So I do think that also having conversations about how to present that data and how to present what you know are important. That being said, it's kind of nonsense that patients in pain have to do that, right? It's
Yeah.
nonsense that patients in pain have to present themselves in a certain way or be worried about someone else's feelings or any of that, right? That's why the system is broken. In a broken system, you're always going to have issues with this. We have to fix the problem. We have to fix the root of the issue. And the root of the issue is this country's not equipped to take care of brown and black people in the way it needs to be. That's the bottom line.
Mm. You want to
Well,
add
that's
something?
a mouthful.
It
Um,
is. It's the
I
truth.
kind of want to piggyback off of Mia's question, because, like you said, you want to be you want the most knowledgeable person about sickle cell in the room, and a lot of times, I do feel like I am, and I'm so far gone from pediatric care, and there's such a big disparity between pediatric care and adult care, and I'm always trying to figure out, the best approach, and trying different approaches every time I'm in the hospital. Like, okay, well, maybe if I present it this way in a softer tone, or maybe if I, present it as a suggestion instead of, like, how do I, as a patient, not even in a transition area, but as an adult patient, how do I present it as like a non-starter for you to not do what it is that I need you to do for myself, while
Right.
Right.
also remaining respectful of your knowledge as a medical professional, because I never want to step on anyone's toes, but at the same time I want to get the best care. Like, what do you do when you've kind of exhausted like the whole chain of command?
Yeah, I mean, that's such a tough situation, Jennifer, right? Like it's already a tragedy that you have to have this type of conversation, right? Um, the system has already broken down at that point, and there's no one sure shot way of ensuring that you're always going to get empathetic, respectful, thoughtful care, right? There's no magic to this. I think that asking for what you want directly, requesting that it be documented in the chart, and ensuring that you know what channels of advocacy are available in the hospital you're in is the best approach. I think that having a conversation around what your care has looked like in the past, what has worked for you in the past, is probably the most successful approach. Um, but again, I think that it really shouldn't be like this is a conversation I should be having with my physician colleagues. It's like, how do I talk to sickle cell patients, right? It shouldn't be your responsibility as a patient to figure out how not to hurt a physician's feelings, or how to approach this so that you get care you deserve. You should always get care you deserve,
Right.
right? You should always get that care. And it's just so sad to me that I have to have this conversation with a warrior instead of with a colleague. We have a broken system. There's going to be a lot of different ways in which you find it broken, and there's not going to be one tool that can fix it. It's going to take consistent, ongoing discussion and lots of different methods to try to make it better.
Now, are you like that blunt with your patients and parents? Do you tell them, hey, once you get, especially the ones that are close to aging out, do you tell them straight up, hey, listen, when you get to adult care, you'll probably deal with such and such and stuff because you're black or you're brown? Do you have that conversation with the parents and the patients?
100%.
Good,
In exactly those words.
good.
How do they
Uh,
respond to that conversation?
I think they're mostly shocked up front,
Mm,
that conversation is even happening.
yeah,
Um, but it's information that they, I think, deserve to have, and it's something I think they need to know. They need to know that. I think part of the problem is not acknowledging it as a physician,
yeah,
um, is damaging, right? I think that hearing your physician say it is very helpful. Even if I'm the only doctor they ever come across that acknowledges this, It's something that has happened, and it's something that's been acknowledged, and it's something that they've heard from a physician. I think that that's an important foundation piece in building trust back in this system, right? In this very
Yeah.
broken system. I think that us saying it is important. I was reading a book called Caste, which is a very good book that you guys should look at. It was part of Oprah's book club actually a month ago, and in there he draws a the author draws a really interesting example. He talks about when you're treating a new patient. When you're treating a new patient, you get obviously you learn about their symptoms, you learn about what their life looks like, you do a physical exam, but part of it is you sit down with them and ask them what kind of problems the generation before them had, right?
Mm-hmm.
And you ask them what kind of problems the generation before them had, right? And you get this really detailed family history where you're really clarifying and solidifying the type of issues that generations past have dealt with.
Yeah.
Because as a physician, you won't ever suggest a treatment plan or come up with a diagnosis without taking that family history, right?
Mm-hmm.
You need to know what generations past have gone through before you can properly treat the current generation. And I think that knowing that racism and prejudice is as intertwined as anemia and hemolysis,
Mm-hmm.
it is crucial
Mm-hmm.
to treating the sickle cell patient.
Yeah, and I think the fact that as a community, as a black community, we've dealt with so much mistrust and so many things when it comes to healthcare, and it makes us distrustful. And the fact that now we're still going into this system, like you said, that's broken, and we're still having to deal with things, and the trust part is not being healed. I think it's
Yeah.
getting worse. So it's like, I honestly, for me, I feel trapped or I feel stuck because I don't know where to go. And I'm just so, COVID made everything worse to me. Like, I kind of feel like COVID exposed the disparities that we have in the community. However, when it comes to sickle cell, I think we have been pushed all the way back. Um, so it's to me it's kind of worse now because I personally feel stuck. I don't know where to go. I don't really have trust with one of my doctors. That's just one. So it's like, what do we do? Um,
Yeah, you're right. I mean, COVID very clearly, I think COVID showed the rest of the country what the sickle cell community has known for a really long time,
yep.
right? So all of a sudden, people were sort of like, "Oh my God, why are so many Black people dying? Why are Black and Brown communities dying from COVID in disproportionate amounts?" And it's like it was a shock to everybody else. Like,
Yeah.
why is this happening? We didn't expect this, but it's sort of like, wait a minute, you've set up these communities to fail already from a health standpoint,
Yeah.
right? You this should not be news to anybody.
Right.
And as a sickle cell community, we've known this forever. Like, sickle cell disease patients are at the back of the bus,
Mm-hmm.
and that's how it's been, and that's how it is. And it just happens that in this country, the sickle cell patients are Black and brown, right?
Yeah.
So it just compounds on top of the racial health disparities that already exist. I mean, we already know that if you're Black and have cancer, your outcomes are worse, right?
Mm-hmm.
We already know if you're Black, you have more heart disease and more diabetes and more chronic kidney disease. These are facts. You add sickle cell to that, and it's a whole different ballgame.
Yep.
But that sickle cell community has been loud about talking about this for a long time. It's just nobody's been listening,
Yeah.
right?
Yeah.
Right.
Yeah. How do
And like we're trying even more to raise our voices and unify even harder in these days and times, and it still feels like maybe we're making baby steps now,
yeah.
but when Mia said that she has trust issues with one of her doctors, I feel her on that. I have the same issue, and to the point where it's like, okay, we're in the midst of a pandemic. I really don't feel well. There's a lot of stuff going on, and I'm afraid to go to the hospital. But being afraid to go to the hospital is another part of the broken system, is another part of the problem, because
Yeah.
I don't trust the system that's in place to help me, but then staying at home, that doesn't help me either. So again, to piggyback off of me and saying feeling stuck, that's a place that I've been in for months now, especially after, contracting COVID in the hospital. I'm like doubly afraid of going anywhere.
Yeah. It's just scary. Have you come across any of your patients that have contracted COVID, and how did they do if so?
Yeah, so we recently published it actually. We published a case series of patients that were from New York, Boston, Chicago, and Detroit. And fortunately, I can tell you that in Detroit, because I take care of pediatrics, the oldest patient that I have is about 25 years old. Um, None of my patients had a bad outcome from COVID,
Good.
thankfully. Um, in the entire cohort of about 70 patients, there was about a 10% death rate in that cohort, which is huge, right? Compared to the general population, which is sort of closer to 3%. Um, so it was clear that COVID causes problems for sickle cell patients, especially those who have kidney disease, pulmonary hypertension, asthma, right? Um, it seemed like the patients who were dying were also the ones that weren't on any disease modifying therapies like hydroxyurea or any of the three new ones. Um, and those patients were much older, so they were much older. So it was clear that the comorbidities you get with sickle cell disease contribute to whether or not you do well with COVID
COVID
19.
or not?
So
Okay.
you mentioned like the patients who weren't on any type of like hydroxyurea. Is that also including like the Oxbryta and the
Yeah,
Adakveo? So
yeah,
I have a question about the Oxbryta, the Adakveo, and the Indari.
sure.
Are those, because I'm on Adakveo,
Yeah,
and I was just wondering, at what age do you think that being on either of those therapies is useful, helpful, and
sure.
what is the result of being on it? Because I'm on it for now 7 months, and I don't know if it's working or not. Like, I don't. What should I be looking
Yeah.
for? What should patients be looking for?
So the first thing I should disclose is that I am a consultant for these companies, both Global Blood Therapeutics and Novartis, but also others. Um, and I wanted to just put that out front. When we talk about Adakveo, we're talking about, for the first question you asked was about age. So we know that from the clinical trial that Adakveo is useful in, or was studied in individuals 16 years of age and older.
Okay.
Um, the key finding was a 45% reduction in VOCs, right, or vaso-occlusive crisis. So my thought would be that in an individual who I'm starting on Adakveo, I would expect there to be less pain,
Right.
perhaps shorter vaso-occlusive crises when they do come, maybe longer time between one crisis to the next. Um, a reduction in perhaps acute chest syndrome, right? These are things that I would expect in a patient that I'm starting on Adakveo. I have had pretty good luck with my patients in Adakveo. Most of them feel it pretty quickly. They start feeling the effects of it pretty, I would say reasonably fast. and have seen a tremendous reduction in the way that they're using the hospital.
Good.
Okay.
That's really good. I
Well, that
just,
sounds promising, at least for me.
yeah. Do you think the age difference may have a factor on how quickly um someone will respond to it?
Yeah, no, that's a really good thought. It might be that, and that's true for many of the things, right? Hydroxyurea seems to not work as effectively or efficiently in our older sickle cell patients, right? It seems to work really well in pediatrics, and then as you get older, seems to work a little less. And that might be true for the other therapies as well.
Interesting.
See,
So,
this is sort of the conversation I have with parents, right? We talk about how in pediatrics, the the way a child looks with sickle cell disease when they're 10, 11, 12 is not how they're always going to look, right? Sometimes we get so fixed on treating the 12-year-old in front of us. And I get the narrative from parents back, well, she looks so good. Like she doesn't need to be on anything. She looks great. And what I try to tell them is I'm not treating the 12-year-old version of your daughter, right? What if I put her on hydroxyurea? I don't expect. I mean, I do expect that things will get a little better, but I'm not really treating this version of her.
Right.
I'm treating the 30-year-old version of her that's going to be a mother. I'm treating the 60-year-old version of her that's going to be a great grandmother, right? We're talking about how life is going to look decades from now,
Right.
right? That's what we're talking about. That's what's at stake here,
Right.
because the biggest lie ever told is that sickle cell disease is a disease of pain,
Mm.
right? Yes, of course there's pain with sickle cell disease, but that's such a damaging way to think about this disease, because what it does is it minimizes any warrior story with sickle cell who's not having pain,
Mm.
right? It
Right.
steals their story from them,
Yeah.
because there are warriors who don't have pain. And those warriors still die young. They
Yeah.
still die 20 years younger than they should be. But their whole life, people have been telling them sickle cell disease only matters when you're having pain. If you're not having pain, you're doing well. And
Mm.
that's something that I try to really reinforce with my families is that don't let anybody take that from you, because
Right.
just because you're not having pain doesn't mean that sickle cell disease is not nasty and it's not stealing things from you, right?
Yeah.
yeah, like with your organs and
Yeah.
all those other things that get, you know,
Right,
blood cells running through them.
right,
Yeah, and I tell people often I have SC, so I don't have as many acute pain episodes as someone with SS, but I definitely deal with chronic pain most days. And even, that varies on how bad it is, but I still deal with, I've had both of my hips replaced. I deal with eye issues. I deal with hearing issues, all because of sickle cell. So
right.
it may not, like you said, it may not be pain all the time, but I am dealing with these other issues that are ongoing and need to be addressed because of sickle cell. So, and when I was younger, I was, as some people put it, healthy. I was larger than most of the sickle cell patients. So people would look at me and just say, "Oh, you one of the healthy ones." And it would confuse me then because I'm like, well, I still have sickle cell. It doesn't, just because I'm a little bit bigger doesn't mean that I'm healthier. And I even get that stereotype now. You look healthy. If
Yeah.
y'all could read my medical records, I
Right.
mean, I take that as a compliment, but at the same time, I was like, I wish that was the case. I wish I could see normally. I wish I could hear normally, walk normally, and all those other things. So, just the fact that, it's so many things that you can't see with this disease, and that's what carries that stereotype is, oh, well, she looks fine. And with me, going into the hospitals for pain, if I'm interacting with a doctor who has a little bit of knowledge about sickle cell, the first thing they do is look at my blood work and see that everything is okay. And it
Yeah.
confuses them because it's like it's not lining up. Like she says she's in pain, but her blood work is normal. So I'm looked at like I'm crazy or I'm pushed out of the hospital because my blood work is fine. But
And that's
nobody,
another thing. That's another thing, Mia, that I don't know how to get rid of that. I don't know
yeah,
how to make people understand that there's no laboratory blood test that shows pain.
yeah,
That's not a thing.
yeah,
There's no labs for that. I don't know how to fix that, except tell every single medical student that I interact with, but that's not enough to make a difference.
yeah,
Yeah, because there's so many like coming up, and they're getting trained by people who may have been trained by someone else who had some kind of faulty thinking.
yeah,
And like what I like to say is that sickle cell is like chicken noodle soup. Everybody makes chicken noodle soup. Everyone has their own way of making it based on what they learned in their family. You know, like Mia might put spaghetti in her chicken noodle soup. I might put rice in mine because that's my genetics. My grandma did that. My mom did that. So you can't treat every person with sickle cell the same way. You can't be like, oh, sickle cell, okay, this thing check, this thing check, this thing check. Now you're better. Let's look at these labs. And the fact that people are being trained over and over again to look at labs and be like, okay, well, you know, your hemoglobin is this. It should be fine. You should be good to go. Even when I go get my infusions of Adacvio, after seeing my physician, I'm waiting sometimes for 30 minutes because the nurses who are supposed to do my infusion are confused by the fact of my blood count maybe being a little bit low, or you know, comparing it to the last time, and I have to be like, well, when you saw me the last time, I just came in from a blood transfusion. It's not always going to be the same.
yeah. Agreed. So you mentioned earlier that you've been studying pain, basically. Um, Someone reached out to me about trying virtual reality to address pain. I'm sure it doesn't completely take it away, but I don't think that would be any different from us, being on our phone and playing a game or anything like that.
Right.
Do you, or what alternative things besides pain medication do you advise to your patients to deal with the pain that they're in?
Especially technology based, because that was interesting to me.
Yeah.
Yeah. So we are actually exploring kind VR headsets
Okay.
at our institution. We're just starting to get into studying it a little bit more clinically. Um, there, the way that we're looking at it though is in relation to IV starts,
Okay.
right?
Mm-hmm.
So we deal with pediatrics, and sometimes getting kids situated during an IV start is not easy.
Okay.
So we're seeing if adding virtual reality to that environment will be helpful. From a pain standpoint, deep breathing is something that we always talk about. Um, there are certain apps that we use to, to push that. I work really closely with Dr. Sherney, and she has this whole slew of apps that she offers, she gives to kids or tells them about to start trying. Pain is a tough one. Pain is a tough one. I'm going to stick with that chicken noodle soup analogy, right? Everybody's pain is different. Different things work for different people,
Yeah.
and pa- patients usually have a pretty good idea what works well for them and what doesn't work well for them. It's amazing to me that the sickle cell mutation is the same in every single person, but every single person's story with sickle cell disease, everybody's experience with sickle cell disease is different. Um, even siblings, right? There could be two sibling warriors with sickle cell disease who have different experiences with how the disease is showing and what works for
Yeah.
them. I personally, I love doing stuff like this, and I love being on social media, Clubhouse, hearing people talk about their sickle cell stories, because as physicians, we don't learn about sickle cell disease in medical school, right? We learn about sickle cell disease by taking care of sickle cell warriors,
Yeah.
right? So the more you hear from sickle cell patients, the more you learn. When one patient tells me, this lidocaine patch really helped me during this admission, I'll say, oh, cool. Let me try it on someone else because it helped this person, right? Nobody in medical school is telling me about lidocaine and sickle
Yeah.
cell disease, right?
Yeah.
That's not happening. I'm learning from you guys. You
Yeah.
guys are making me better. And that's, I think, an underrated part of all of this is it's, I'm not going to say it's your duty as a sickle cell warrior to make things better, but you guys play a big role in what doctors know about sickle cell
I
disease,
feel like
right?
it's our
Because
duty.
it is, right?
I do.
You're making it better for the
Yeah.
next generation,
Yeah.
because everything you say, everything that works or doesn't work for you is something that goes into that doctor's mind,
Yeah.
and it's something that they put in their toolbox or take out of their toolbox. Um, so I don't have a clear answer to that, to things that I suggest for pain that are, non-typical or atypical. But I will say that I've learned a ton from different warriors about what works for them. And I think that those types of conversations are really helpful for me.
Yeah, we've
Yeah.
had. Go ahead,
Go
Jennifer.
ahead, Mia.
So we've had our previous shows where we discuss what we do for alternative pain meds. So for me, yeah, deep breathing definitely helps. Not all the time. It's kind of hard for me to meditate sometimes, but one of the things that I really like to do when I'm stressed is to paint. And sometimes if my pain is really bad, then I might just stay in the bed and sketch something or color something. But if I've taken something to kind of lower that pain and I want to kind of remove myself from everything, I'll just paint. And that helps with the mental stress part and the emotional part. And of course, all that plays a factor in the physical part. So we've definitely had shows where we discuss different things that have worked for us. So you wanted to say
That's
something?
great.
Yeah, I was gonna say that um, for myself, I use music as a therapy.
Yeah.
So I was wondering if that was something that you guys use for your pediatric patients. At one point, my son was talking about um, being a musical therapist and seeing how music, I guess, makes pain react. Like when you hear certain types of music, does it make the pain calm down or what have you? But I know, like for myself, it helps to blast trap music. Like
Yeah.
that's just what I do. And in the hospital, it's like, oh, you must be okay because you listening to this music. Like, no, it's a distraction technique. It's just
Yeah.
something I need
Right.
to distract my mind from what's going on in there.
Yeah.
Kind of like trying to rewire the synapses in there.
Yeah. Yeah.
Yeah, no, I mean, you got to do what works for you, and
Yeah.
who cares what anyone else thinks? You are the expert as far as your body goes. I feel like sometimes we oversell what doctors provide. Um, See, if you think of your pain crisis as a mountain, you've got to climb that mountain yourself.
Yeah.
And doctors are just there to maybe guide you in the right direction, maybe offer you a couple tools that you didn't have access to, but you still got to climb that mountain yourself. So whatever
Yeah.
gets you over that mountain, you've got to go with, right? My job is not to get you over the mountain. My job is to be like, all right, here, maybe this IV bolus will help you along your way, right? Maybe this dose of morphine will help you get a little bit higher over this mountain. That's all I'm doing, right? I'm just pushing you a little bit more and more, but it's really, you're the one in the end as a warrior that knows what's going to get them over this hill.
Right. Now, one of my.
I'm like a Sherpa up on the mountain.
Uh oh, you froze.
He said he's like a Sherpa on the mountain.
Oh, did I froze?
Okay, you're
You're
back.
back. You're
Am
good.
I
Um,
am I still frozen?
no, you're
No.
good.
Okay, it's telling me my connection is unstable.
Oh no. Um, one of my concerns is when the pediatrics section or part get the medicine that they have. My concern is it builds up their tolerance so that once they get to that 18 or even 25 or an adult and have to deal with the healthcare system, their tolerance for pain medicine is like through the roof. And that's part of the stereotype with them coming in there with crazy doses of medication that works, plus the long lasting effects of having to take Percocet or morphine or Dilaudid every day. How do you balance that so that, because it's kind of like either the sickle cell is going to lead to organ damage or the pain medicine is going to lead to organ damage. So it's like pick your poison, how you want to do this. So how do you balance that? Like, what do we tell the young adults coming into adult care on how to balance that and being mindful of what both sickle cell and these hard pain medications are doing to them? Did that make
Yeah,
sense?
so I mean, this is a challenging question. Um, you want to treat pain, right? And you want to treat pain aggressively up front, especially when it hits you um, in an acute crisis. But you're right. Opioids, forget opioids. Everything comes with a cost, right? Everything you put into your body comes with a cost, right? A piece of cake comes with its own cost, right? Anything that goes into your body has a price. Opioids have a price. You all know this very well. The side effects of opioids, the nausea, the headaches, the itchiness, right? The constipation, the long-term effects. These are all real issues. And you're right, the tolerance builds as you get more and more opioids. That being said, when the only tool you have is a hammer, everything looks like a nail, right? And that's kind of where we are with opioids and pain management. Right now, it's the best chance you have at getting a little bit of comfort, a little bit of relief. Are there other things that can work? Potentially, yes. Should we be a little bit more open-minded about clinical trials and pain management? Yeah, probably. There are other non-opioid measures that we can use a little bit more liberally. Um, but it's a very fine balance to walk because you also don't want people to be uncomfortable,
Right.
right? I don't want people to be in pain actively. Um, I think that with my patients, the approach we've taken has been um, empowering them to make the decision themselves by understanding what the cost of opioids is, right? So if they are comfortable, they know that when they feel like they can get to their home meds, they're pretty quick to push themselves onto their home meds. Um, but I reassure them that when they're in pain, they should get the pain medicine that they need.
Yeah.
Because while the opioid overdose rates in this country are skyrocketing, 350% up, the rate of opioid overdose in sickle cell disease patients is near zero, right? That's not a thing that happens in sickle cell disease because often when you take pain medication during crises, when you're taking pain medication when you're supposed to, the chances of overdose are tremendously low. But you're right, the cost of tolerance is a big one to pay, and there are going to be hefty doses of opioids that are needed. Um, I hope that as we go forward in the next few years, we come to a place where we have a lot better as far as non-opioid agents to treat pain.
Yeah. That would be
Um,
awesome.
since okay, we've discussed that you're a physician, so that's not news to anyone. But why is it that other physicians, other hematologists who have been practicing medicine for however long, dealing with sickle cell patients, don't understand in the same way that you do about treating pain aggressively. And again, there goes the thing about respecting your patient enough to know that, like when I'm in the hospital, I know usually what I need as far as dosaging and stuff like that. And I also know when I'm ready to like start weaning off and I'm ready to be put on like my home meds. So why is it that it's so hard to get, and I don't even know if this is like a question that can really be answered, but why is it so hard to get the vast majority of medical professionals to understand it the way that you do?
Um, yeah, you're right. I can't answer that. I guess the way that I can approach that is by telling you that there were people who taught me, right? Um, I had teachers that got me to this point, and um, what I mean by that is there is some good in the world, right? And it's a matter of, um, unfortunately, sickle cell patients don't have the luxury to say, I want to go to such and such doctor, or identify which doctor stands where on this issue. I think that when you're well, having this conversation with your doctor when you're well is something that's super important, right? Like, can we write down a plan for me for when I go to any hospital to take with me? Having that discussion up front when you're not in pain is so much easier, so much better, so much more valuable. But again, unfortunately, I don't know why it's so hard for people to believe that sickle cell disease is catastrophic in the way that it causes pain. I mean, what we're talking about here is the blockage of blood flow from sickled red blood cells, white blood cells, and platelets, and remembering that blood's job is to deliver oxygen, and now you're blocking the delivery of oxygen to tissues. I mean, I often say this, sickle cell disease is literally just another form of I can't breathe, right? But it's just happening at the tissue level. It's not a knee on your neck, it's in your body at the level of wherever you're having that blockage happen. And if people don't understand that or can't see that, you can't teach empathy, right? I guess it's something you either have or you don't. But self-advocacy, having other advocates around you is important.
Yeah. That was a good one. You dropped a lot of gems in there.
Right.
Sorry, I talk a lot. I'm
That's
sorry.
okay. Don't
No,
apologize. We love it.
it's a bunch of good stuff in there,
Yeah.
packaged very nicely.
Yeah, we need to just clone you and just put you in each state. So, what I probably should have asked this in the beginning. What made you come to the sickle cell community? Like, how did you get involved? Is it strictly through your work, or like, how did you just become so passionate about the sickle cell community?
I There's a couple things there. I think that the first thing is in 1999, my nephew was born, and his newborn screen came back positive for sickle cell trait. And up to that point, I was in high school at that point, and I had only heard of sickle cell disease in Black people, right? And when my sister told me, I was like, wait a minute, that only happens to Black people. What are you talking about? And of course, as I started understanding a little more about what actually sickle cell disease is, I didn't realize how big of a problem this was in India, Pakistan, the Middle East, right? Other places. It's globally not a Black disease, right? Globally, it affects Black people, it affects white people, it affects brown people, it affects the whole spectrum. Then something really cool happened. I went to medical school in the West Indies. That was the best thing that could have happened, right? So when I went to medical school in the West Indies, I got to see sickle cell disease myself for the first time in a developing country. and they had nothing. They had no opioids, they had no blood bank, nothing.
Wow.
What they did have was a whole bunch of respect and empathy for the patients.
Nice.
Um, and that was really important for me to see early on, how sickle cell patients are cared for in a non in a setting that has no or limited resources.
Right.
Then when I came to Detroit, of course, I got to be in the company of some really good doctors, Dr. Sherney being one of them. Um, I saw how it looked to have sickle cell disease in a developed country, in a country that has resources, that has opioids and blood banks and transplant and all sorts of stuff. And then I got to see the difference during my training in how cancer patients and sickle cell patients are treated. And being a doctor is not, it's not all it's made out to be. Some really hard days, right? You spend half your time practicing medicine in a way that just makes sure you don't get sued for something, right? We practice defensive medicine. I spend a few hours a day talking to insurance companies about stuff they don't want to do.
Wow.
This is not what you expect when you're a physician, but that's part of the gig here in America. So I knew quickly that I needed more than just taking care of patients and writing notes to get through my days. I needed something that was worth waking up for, right, every day. And as I saw the struggles and disparities and the struggles in bias and prejudice that my sickle cell patients were facing, it became clear to me that even if I stopped being a doctor, this is something that I could be passionate about, be excited about, be satisfied doing for the rest of my life, standing up for sickle cell patients, fighting prejudice and racism and bias in the medical system, trying to rebuild this bridge that's broken down between patients and doctors. This is something worth doing. And that's kind of how I got to this point.
I love it. I
That's a good story.
Yeah, that was awesome. I love it. I'm super grateful for your experiences and your passion because we need that in the sickle cell community. Like I said, I just wish we would we could clone you, and or at least give tips to other physicians because I feel like the doctors are more willing to hear from someone like you than
Than
someone like
someone
me.
like us.
Yeah, so it's really,
Trust me, they don't like it when they hear it from me either.
that's okay. You'll get more respect than we do.
Like
I get
sometimes,
into I get into a lot of good trouble.
Good.
that's good. Sometimes I feel like speaking my mind is like the last thing they want to hear.
Yeah.
But I really hope that your message spreads like wildfire because it's something that's important, not just to Mia and I, but to Mia and I for the generations coming up behind us.
Yeah.
I want to leave this world in a better place than I found it,
Yeah.
especially for those fighting sickle cell. And not only sickle cell, just other healthcare disparities in the Black and Brown communities.
Yep.
Same,
Yep.
same.
Awesome. So this was great. Thank you so much, Dr. Z, for joining
This
Thank
is
you.
us.
most enlightening.
It was very enlightening. I already, after watching your TED Talk like a few times, I watched it a few years ago, and then I just watched it again because I already knew I wanted you on here. Whatever date you told me, I'm like, okay, we're going with that
We're gonna
date.
do it.
Well,
So,
thanks for having me, guys. I appreciate the love.
yes,
But trust me when I say there's a lot of good doctors out there who are trying to do good things.
good.
It's just a matter of finding them.
I have a
That's
few on
comforting.
my team,
Awesome.
but I have one that I struggle with, but I'm working with her.
Yeah, that's comforting to know. We're gonna keep trying to find the type of doctors that we need.
Beautiful. I love it.
So let's jump into our sponsors really quick. We want to thank Apex Museum and Mr. Dan Moore. Check out the website because we can't, of course, go in person. So check out the website when it all opens up and we can go. Please check out the museum because it's absolutely amazing. I can't wait to go
Make
back.
that your first stop.
Yes, Then we want to thank Kid Stop Daycare and Learning Center with Tanya Robinson. She is still making things work with virtual learning and just helping those kids out get the work that they need to do. So, and we want to thank Black Professional Network for everything that they've done. So be sure to follow us on social media, Sickle Cell Awareness 365 at Instagram, Facebook, Twitter, and TikTok. Also follow Manifest TV, same platform, social Facebook, Instagram, Twitter, and oh, I did
Remember to tune in later on this month for our surprise that we have for you guys.
and tune into social media so you can keep track of what's going on. One last question. I did want to ask you to repeat the book that you mentioned, Cast. Is
Oh
that it?
yeah. So the book that I mentioned is called Caste, 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 The Origins of Our Discontents, and it's by Isabel Wilkerson.
Isabel
Okay.
Wilkerson. Okay.
So if you had a moment, check that book out. I'm sure it'll be a good read. It'll be something that I can read at night.
Yeah, me too. All right. Thank you again, Dr.
Thank you
Z. I
so
really
much for
appreciate
joining
you.
us. We really, really appreciate it. Thank you for your time.
Thank you. Hold
My
tight.
pleasure, guys. Take care.
You too.
Bye.